Hi, I'm Dr. Henry Black. I'm a clinical professor of internal medicine at the New York University School of Medicine and part of the Center for Cardiovascular Disease Prevention. I'm also president of the American Society of Hypertension. Today I'd like to talk a little bit about using non-clinical trial information to get us data we can't necessarily get elsewhere. What I want to talk about is the incidence and presentation of atrial fibrillation in patients who were part of the Systolic Hypertension in the Elderly program, a clinical trial which was begun in 1984 and completed in 1991. The SHEP study, as it's called, was very clear that treating older patients with isolated systolic hypertension, defined at that point as being more than 160 and less than 90, benefited from active treatment. We don't do too many active placebo-controlled studies now. We do active control studies because we now know that there are very few instances in hypertension and in hyperlipidemia where treatment can be withheld from patients who have the condition. Well, SHEP analyzed data at the end of its trial, which was about 4.7 years of follow-up, and also they've now extended the data to about 14 years. Now, what I want to talk about is the results from the first part of the study with the second follow-up later. The incidence, that is the new cases of atrial fibrillation, occurred in a little over 2% of the SHEP cohort. The other 98% did not develop that. That's pretty similar to the incidence in the general population, where about 5% of people over the age of 60 develop atrial fibrillation, and about 10% over the age of 70 do or more. So it's a condition that older people see. Well, what was found out about the SHEP study was that of those 98 volunteers who developed atrial fibrillation, they were more likely to be men. They were more likely to have a higher treated blood pressure, not baseline blood pressure, because the baseline blood pressure was the same. But at the end of the nearly 5 years, the patients who developed atrial fibrillation during the trial, this is during the trial, because atrial fibrillation at the outset was an exclusion, had a higher in-treatment blood pressure of only about 4 millimeters systolic, which doesn't seem like a lot. The patients, or the subjects, and we really shouldn't call them patients because they were volunteers and subjects, were more likely to have cardiovascular events than those subjects who did not develop atrial fibrillation. The more kinds of events that they had were not as we might have expected, which would have been strokes, but rather heart failure and to some degree myocardial infarction. What we really learned from this, I think, is that even though this wasn't one of the major issues in this clinical trial, very important information came anyway. So we now know that we've got to be more careful looking for atrial fibrillation in men with isolated systolic hypertension who actually had a little more alcohol use as well, and that what they get isn't necessarily a stroke, but heart failure as well. So these are important things for us who treat patients like that, and we all do, and we all will do even more to be particularly careful about that, because atrial fibrillation increases mortality and increases strokes as well in the general population, although it didn't occur in the SHEP cohort. So this is a very important use of evidence that comes from a trial, but wasn't part of what the trial was supposed to be about. We can't ignore this evidence, even if it doesn't meet the highest standards that the evidence-based medicine folks would like us to look for. So thank you very much.